Hey there, this is Mike Banner, and welcome to the latest edition of 62 Who Knew. This is a different 62 Who Knew. In the past several months, as our audience continues to grow and grow into the thousands and very, very soon tens of thousands at the rate we're growing. But we're always talking about something very tangible, whether it be long-term care insurance or retirement benefits or annuities or life insurance and all the many things that we talk about. Today, we're going to talk about something that's a little intangible, but just such a part of people's lives that it's just unbelievable. But before we get to that, and before we introduce this week's guest, I do want to tell all of our new listeners a little about what we do here and what is 62 Who Knew. Well, 62 Who Knew was created to discuss the double-edged sword of longer lifespans. It's so wonderful that in the last 20, 30, 40 years, medical breakthroughs, scientific breakthroughs have brought us so many things that we're living longer and longer. There's so many examples to that, so many women's cancers, men's cancers, that if you catch in your first couple of stages are literally 90 and 95% curable today. And so many other examples. I mean, let's face it, in the 90s, if you tested positive for HIV, that was a death sentence. Today, you take your medicine and you live a great life. And it's just so many things. My grandchildren don't have to worry about diseases that I literally got shots for when I was a kid. They've never even heard of those diseases. And the truth of the matter, what has happened in the last 30 years, those medical breakthroughs are nothing compared to what's coming in the next 10, 20, and 30 years. This next 20 to 30 years will make these last 30 years look like Fred Flintstone time. So 62 Who Knew is about, if you make it to 62 in this country, you have a 50-50 shot of making it to your 90s. And the great majority of this great country and the world, and when I say the great majority, I'm talking 98% of people are woefully unprepared to be in their 60s and then live to be in their 90s with a high quality of life, mentally, emotionally, oh my God, physically, and of course, financially in today's world, to live 25, 30 years with a high quality of life. So 62 Who Knew every week brings on an expert that in a specific category gives you actionable advice. And then we take you right to the 62 Who Knew website, www.62whoknew.com, where you can click on the site and contact that person and talk to them about the legal things that you may need, documentation, annuities, Medicare supplements, whatever it may be. That's why 62 New is here, to make sure that the last 30 years of your life is the best 30 years of your life. But today we're not going to talk about a product. I guess we are going to talk about a service, but not a product. So I never really saw, no matter how big our audience grew, and our audience is growing rapidly, I never really saw us, Anthony, probably discussing aliens and intelligent life. Maybe one day when we're over 100,000 a week, we will have that discussion because I am the world's largest trekker. But aliens do have a little to do with today's episode, because if you don't believe that there are angels on this planet, then you have never had the experience to have a hospice worker come into your home. I've had that experience with my mother and my father, which I guess is most people's first experience, because when your grandparents die, you're very, very young. Hospice probably was involved with them, but I don't really remember hospice with my grandparents, but with my mother, my father, I certainly do. And like I said, I've discussed this with so many people over the decades, business people. They say good help is hard to find. A good receptionist, a good server, a good mortgage person, a good anything. Yet somehow these incredible human beings seem to gravitate to hospice and walk into your home, become part of your family. And what they do is just staggering. So today's guest is, in fact, one of the best examples of that staggering angel, Miss Kim DeLeon, who has been with the Northeast Georgia Medical Center of Hospice for the last 12, almost 13 years. I'm not going to go through her whole resume because it's incredible, but has been taking care of people really since you got out of high school. So everybody like we have people here, right? And the crowd goes wild. There is no crowd. Everybody welcome Miss Kim DeLeon, or Kimmy,
Hi.
as she is called.
Oh,
Yes. And I am very, very proud to say, some people say you shouldn't say this on air, that it takes away from things. I don't think it does because Kim's maiden name is Banner, so she's my niece, and she is my cousin Bob's oldest daughter, and just such a staggering human being, and not just for what you do with strangers every day of your life, but with our one left greatest generation matriarch left in the Banner family, my Aunt Helen, your grandma, your dad Bob's mom, Helen, who is what now, about 112 years old? How old is Aunt Helen?
95. She'll be 95 in
And still just a firecracker. Just a
Yes.
firecracker. When I talk to her, I get off the phone and go, number one, I don't think I'm going to make it that long. Number two, if I do, to have that attitude is just staggering at 95 years. So before we go into specifics, I have to ask, when did you know, because I know you since you're born, and you were always an incredible child, when did you know you just wanted to do this for people? I mean, I don't understand how a hospice person goes into a person's house to this day. And I'm a few weeks away from being 67. How people like you come into a house, give your heart to the entire family, especially the patient, but more sometimes the entire family. And then, of course, there's never a happy ending. We were just talking about that before the camera came on. It's always the same ending. And you give your hugs and you cry. And then you go to the next house. I don't understand it. It's beyond my mental grasp. How do you do it? When did you know you wanted to do it?
So I was a registered nurse at 21. So I was a very young nurse. So nursing's a lot like maybe military in reference where you're the grunt when you're young and you're new in the profession. And so I worked in Boca Raton, Florida, very, the age of that population, very elderly. And I worked on a heart floor as a new grad. And as patients would come in and I'd see, my goodness, this patient is advanced age, advanced illness, and we're doing all these things. We're doing chest compressions and they're hooked into the bed, and the quality of life, quality of quantity was always something. Even young and not understanding why I was thinking those things, but I always questioned, why are we doing this to these folks? This isn't a quality of life. When there's hard conversations, I was kind of the little person they'd go and get and have those conversations, and it was just very, I didn't ever set out to be a hospice nurse. End of life typically would be assigned to me.
Mm-hmm.
After I had my second daughter, I'd been working for 5 years in the intensive care units in the hospital. My boss had become a director over at the hospice, and she says, come work for me. And I said, I don't think I want to do that. And I'll never forget, she says, Kim, it's just giving morphine and hugs. And I just thought that
Morphine
was
and
funny.
hugs.
And I was like, okay, I'll check it out. It actually wasn't being in people's homes. It was a standalone hospice house. So we had 30 beds. We were a not-for-profit hospice in South Florida. South Florida is a little different. Different states vary with how many hospices they can have. So in Florida, there's a certificate of need. So, there's only 2 hospices per county. In the state of Georgia, they don't require a certificate of need. So just in one county alone, in the county that I work in primarily, we have 23 hospices.
Oh my
So
God.
it can really differ from state to state. So when, not every hospice is built equally. And if you really take a deep dive into hospice, over the years, it's, people have discovered, there's always people in it for the wrong reasons. Because really you could just open a
That's
hospice.
human.
Yes. So anyways, I got into that, working in that unit. I worked there for 7 years. And I loved it. It took me a mental adjustment, knowing that these people weren't going home. And I just got really good at it. And then when I moved to Georgia about 13 years ago, they didn't have a hospice house. They're very few and far in between. Most hospices don't generate enough profit to really sustain something like that. And because there's so many hospices here, the censuses are small.
Mm-hmm.
So anyways, I started working for our hospice and going into patients' homes, and it truly changed my life. And I think when you go into someone's home, you see that person as a person, and it was one patient at a time. It's not like, nurses in hospitals that are running and they have 8 patients and it's not personalized care. But when you're sitting in someone's home and you're looking at their pictures and you meet their family and their friends, and see how they lived and have that one-on-one time. I just felt like it was a gift. And I feel very strongly when we're born, we have a nurse. And when we pass, we have a nurse. And I have always thought it's just an honor for me to care for someone at the end of their life because it doesn't have to be scary. And I think, honestly, most people are pretty aware that they're dying. And when you're not honest with someone about dying, you really rob them of the time that they need to make their peace, to say their goodbyes, to maybe get things in order. So I think just being able to educate people and be honest with people is refreshing. They're hard conversations, but you know, I would want to know. So
Yeah.
I think it's a gift.
No, it's definitely a gift, and quite frankly, I mean, the hospice people that we were involved with my mom and dad, it's hard to believe. Dad is what is today, May 14th, 15th,
I
14th,
don't even know.
14th. So
14?
9 days ago, my dad was gone 20 years, which is just impossible for me to think about. I mean, if I were to think about it quickly, I'd say 10 years, 12 years, not 20 years. And
Yeah.
how long is Uncle Sid gone now?
Oh my
Or your
goodness.
grandpa Sid?
At least almost 10.
I would say 9 or 10 years, I think.
Yeah. Yeah.
And it's just, it's when we had hospice in our homes, um, I'd have to say, although they were a blessing to my dad and
Hmm.
my mom, they're just as much a blessing to the rest of the family.
Yes.
And in fact, I'd have to say more, because let's face it, everybody says this, it's a cliche, but when the people are gone, the people that you're there to take care of, they're gone. It's the people that have to live with the loss that I think hospice does such a staggering job. You never can be prepared.
Yeah.
I don't think you ever can be prepared. But by having that hospice person there, it just does, it prepares the family as best as it can.
Hmm.
And we've talked about this on a few of our shows that we've talked about in-home care, even if it's not end-of-life care. It does allow the family, like in my case, it allowed me to be a son rather than a caregiver, or my sister to be a daughter, or my grandchildren to be rather than the person, explaining the difficult things and checking their IV bag and helping them in the bathroom. And it does allow you to be, I think, what you're supposed to be at the end of your loved one's life,
Hmm.
not their caregiver, even though you want to be their caregiver. I mean, in your heart, you
Hmm.
want to say that, but it's more important to be their son or their daughter, or like with Aunt Helen, their granddaughter. I mean, I know how much Aunt Helen gets a kick out of just seeing you, let alone having you take care of her.
Yeah. Yep. She's my favorite.
Yeah, I would say so. So, and that place she's in, I happen to like that place. I don't want to be in one of those. It's funny, my kids argue, Dad'll live with me. That'll live with me. I go, you realize I'm still here. I'm not drooling in the corner. Stop, let's have this argument. But, there are times when you just have to be somewhere. And let's face it, in Aunt Helen's case, with her, between her eyesight and her leg, she wouldn't be able to be taken care of in someone's home. She just wouldn't be able to. But talk to me about how the family has no experience with hospice, views you as you're walking in, because you are a stranger
Mhm.
walking into their inner sanctum.
Yes. And that is a challenge. And you bring up a good point and see, it depends on how long someone can stay on hospice. So the national average length of stay for someone in their home is about 90 days, so about 3 months.
I never would have guessed that. Oh my God.
That's the average. And it can vary depending on how early your doctor's giving a telling you about hospice. Some people are like, I'm going to fight till the end. And other people are like, listen, I'm done. I'm not doing all the testing. And, I just want to go home.
Hmm.
So it happens. And this is something that so for hospice to come, you have to have a doctor that refers you. That doctor has to feel that if your disease process, without any intervention, we're not going to do all the life-saving tests and all the things. If we allow that disease to run its natural course, that you would have less than 6 months to live. And that's not saying you have to pass within 6 months, but that is the criteria.
You're not unplugging them at the end of 6 months.
No. And
Time's
I'll
up,
walk
Mabel.
through.
Sorry.
Yeah, so time
No,
to
go
go.
ahead.
And you can be on hospice for years. It's not the common thing, but I can explain how we do that. And hospice is very, very regulated. We fall under, CMS for Medicaid, Medicare. That's who pays us. If you're not of Medicare, Medicare age, private insurances also have, most of them have a hospice benefit. But a lot of times what happens is that doctor will identify that you meet criteria. And a lot of times that's just from having those conversations. What is it that you want? You're 75 years old, we found all this cancer, you're in heart failure, whatever it might be, what do you want to do? So we run into some problems when hospice shows up to the house and, it's an admission nurse. It's somebody who's doing the intake, explaining all the things, explaining your benefit, explaining it's free. We sign you up and then we leave because hospice is not there to be a caregiver. So they have to have a caregiver present in the home. So it's very difficult for patients' families who are like, okay, well, now I can't work. How am I going to make money? Like, do I live with mom? Does mom live with me? It's truly like almost this panic. So you're trying to really swallow like, okay, my doctor thinks I'm going to die in 6 months. Some lady's coming in having me sign papers, and now I've got to have caregivers, and it's a very stressful time for some families. And a lot of what we do is educate. So with the hospice benefit, and that's what it is. It's a benefit of your Medicaid, Medicare, or your insurance. So you'll have a nurse visit, and it just depends on what's going on. Sometimes you'll
Right.
see your nurse once a week. Now, CMS says we have to go once every 14 days. That's the minimum. Some hospices will do take that at a minimum. They'll say, well, we'll see you in a couple weeks. And if something happens, you just call us. So when I tell you not every hospice is built the same. So you think, and then you could have an aide visit you.
Right.
There's really no, I mean, truly, you could have an aide every day. It just depends on the hospice that you choose. So it's really important to kind of do your homework. Because if you've had someone who has been on hospice, phone a friend and ask them, how was your experience? Did your nurses show up? Did you have someone to call? Did the aides come and help you, give a bath? Because we might be there for an hour, 2 hours, whatever our visit length is, but then we're out of there. And then it's the family who's um, so we're there alongside of them, not necessarily with them. So there's just a lot of education, and a good hospice will continually, like I know for our hospice, our standard of care, you see an admission nurse, then the next day you see a nurse, and then you meet your primary nurse, like
Uh-huh.
we will make the max visit. And how hospice makes money is Medicare will reimburse a daily per diem rate. So when you sign up for hospice, depending on which county you live in, and it's all CMS will, then those numbers are public and you'll see them when you sign your consent. So they get paid a daily rate. So if you're in this county, it's $180 a day. So this is how hospices can
It's not a
sometimes,
lot of money.
it's not a lot of
People
money.
are not going into this angelic
Mm-mm.
employment. It's
No,
service for the money. That's for sure.
no. And all that money goes into one pot and it pays for all of your equipment. It pays for your nurses, your social workers, your chaplains, your hospice aides, your on-call staff. Where there's some profit, there's areas for profit, and a lot of times some of the smaller hospices, the for-profit hospices, they love to go to assisted livings because those people already have caregivers.
Uh-huh.
They're in a safe environment. So you'll see like there's a marketing frenzy to try to get into these assisted livings, and it's really become quite the thing because if you think about it, those patients need the minimal
That's
because
right.
they already, so that's, you kind of can see some, but the government has put some tough regulations, and you can't, you do have to prove that you're eligible. You can be audited, and you can also be fined. It's interesting. So the government is aware, but yeah, we definitely walk alongside the family in the homes, and we're pretty transparent in letting them know that they essentially are the caregivers, but we're just here to support them, to teach them, to give them what they need to be successful.
If just in case you're just joining us, you're 62 who knew our guest this week is Miss Kim DeLeon, formerly Miss Kimmy Banner, who is a hospice nurse and has been taking care of people her whole adult life. Today, we're not really, although we are going to talk about certain services because we did it in preparation, for the show, you and I, Kim, talking about how so many people are just not prepared with proper documentation and things such as that. But back to the quick commercial. You're at 62 who knew, and today our entire show is about what I consider the angels on earth, which is the hospice care workers that come to your home during your relatives and loved ones' final days, sometimes final weeks, final months. It flabbergasted me with the 90-day thing. I never would have thought that. Um, Now, so that back to a few things. There are so many pieces of documentation that people should have, and so many of our, New York Times best-selling authors that have been on the show that talk about financial planning, long-term care, in-home care, whether it's power of attorney, whether it's a medical power of attorney. There's so many things that almost everyone doesn't have. And when they need it, it's kind of too late to have it. And then suddenly the family's going, what do we do? Who do we do? And one sister says this and one brother says this, and an aunt that used to be a nurse in 1928 says this. Are you still seeing that? I mean, is there a lot of people, like I say in the beginning of the show, so many people in this country are woefully unprepared for older age.
Yes.
Are you seeing people that are woefully unprepared for
We
what's...
are. And we just did a study in Georgia about only about 28% have, their advanced directives in place. So there's a huge gap. And I work for a large hospital system that's starting to see that. So we're seeing a lot of initiatives in the community, not just through hospice, but through healthcare. Like we have a plan in a can, they call it. So when you're coming in, we're even as a patient, who's going to go home and recover, we're starting to have conversations earlier. And we've had patients, it's funny because you'll say, oh, if I ever get like that, just shoot me, or I'll never want to live like that. And then we get to the end of life where it's like, well, we're there. And then you can't, you don't have the option, like you're stuck in the situation and you not prepared yourself, your family and everyone has to make this joint decision, and someone, like you said, someone will come out of the woodwork, and it's not like it's, oh well, the eldest son makes the decision. It's not that. It's that we have to have everyone has to be on board. So by not really letting people know what you would want, and writing it down. Because
Yeah,
we have
write it down.
so many
Yes.
people go, well, mom told me she wanted me to make the decision. And, son's over there going, no.
Mom never liked you. She liked me
Right.
best. Yes.
Right. And then you're dealing with a lot of blended families,
Oh, yeah.
stepsisters, step parents, and it just gets to the point and there's been a lot of times, honestly, where um and here's the thing, when you die, you don't have to die on hospice, and some people feel like, I mean, you can die and never elect hospice.
Mhm.
Um, but we've had a lot of families that just either can't agree or we can't find someone, if they don't have children and there's really, they're elderly and the parents are deceased and there's just a neighbor, like they can't sign the consents and then we're waiting for guardianship and really in the meantime they'll pass. I mean, we've had a lot of that,
Or
which
in the
is okay.
meantime, maybe they're suffering
They're
because nobody
suffering.
can make a decision.
Yes, 100%
That's just terrible to think about.
is. And, it's very common. And if people would just designate someone to make the decisions and really document what you want. And I think people are really over the years doing this so long. I think we all know that we're going to die, but we don't want to talk about it. Our culture, it's still very taboo. It's scary. And a lot of people think that if they put on paper when you're 62, that I'm a do not resuscitate, that God forbid, something's going to happen where maybe I could, I'm not sick. I don't have cancer, everything's
Mhm.
good. But what if something just happened to me? They're not going to try to save me,
Mhm.
kind of thing. Because people think of, they just think that they're going to be diagnosed with something terminal, but that's not always the case. I mean,
That's
we've
right.
had patients that, I had a younger gentleman. He was in his early 60s. He was going to work that morning and he bent down to charge his phone and he fell. And his wife was like, what are you doing? Thinking that he tripped and fell. Well, he had a massive heart attack. And by 8 o'clock that night, he's in our hospice unit dying. And so you don't think of that. And that happens. It's not always that you're going to be prepared
Well, you're
or
never
diagnosed.
prepared.
You're
Yeah.
never. And a lot of times people do. You just go have your basic checkups and, sometimes you've got that ticking time bomb that you don't know, you're at risk for strokes, heart attacks,
Yeah. I mean, look at our
just
family.
different.
Look at your dad, me, our fathers, all
Uh-huh.
four Banner brothers, um, had cancer,
Uh-huh.
congestive heart failure,
Uh-huh.
everything you could pretty much, not to mention the mental illness that runs rampant in our family. Not to mention that stuff. Yeah, there's that. But that runs rampant in most families.
Yes.
And ours, it just happens to be special. I've said for years, we put the fun in dysfunction. That's
There you go.
what we do. But no, you are is there a such thing as a partial do not resuscitate? I'm not meaning this to be sarcastic or funny.
Mhm.
In other words, I've got in writing to the kids that if I'm going to be resuscitated and be brought back and live on a machine and be a vegetable, pull the plug. I don't want to be. If I have a heart attack, as my father did, as Uncle Sid, Papa Sid to you did, and then lived through it and had another great 9 years of playing three cushion billiards all over the world. Yeah,
Right.
damn well resuscitate me.
Right.
I just
Right.
don't want to be the vegetable.
Right.
Is that too ambiguous, or I mean, how
No.
does some?
Well, most of the time, now in that case, like, you might have something documented that you would have to tell the paramedics, you would have to tell, the emergency room, he's a DNR, you know what I mean? And
Yeah,
so if you're not chronically ill, or if you don't know something's wrong with you, most of the time you're going to be resuscitated,
yeah,
and then your daughter or someone's going to go home and go, wait, when he's on it, when, God forbid you went on a ventilator,
right.
and someone will go, oh, wait, we have that, So, I mean, there are, if you read, an advanced directive or a living will, you can be as specific as you want. You can say, well, I would want, like a feeding tube. Well, if you had throat cancer, but really you were okay and they just had to remove your throat, let's just say, but you were
Just
technically,
had to remove your throat.
yeah.
Yeah,
But like, just say that they had to and you couldn't eat. I mean, you wouldn't want to just say, well, I'm ready to die.
no,
You'd
because
say,
you still can love and hug and see your grandchildren and
but you'd put a feeding tube in,
yeah,
and you eat because you're of sound mind, everything else is okay. So like there's always that black and there's gray area with advanced directives. So you can be very specific in them.
yeah. One of the things that changed my life, my grandmother, your great grandmother, Rose, she lived to be, I think, 97 or 98. And there was a time she was in a nice facility in West Palm Beach. And my father said to me, you need to go down and see Grandma Rose. And because I'm the person in the family that makes everybody laugh. I said, why? She says, because she's talking a little crazy. Been talking to Uncle Sid. She wants to die. Her and Grandpa Joe were married for 60 some odd years. She didn't even want to live past when he died. Greatest generation marriage. She never had a driver's license. She never wrote a check. And she's talking a little cuckoo, and talking about wanting to die. So I took my daughter Stacy and we met Susan and Ashley and we went and we saw Grandma Rose. And I walked in, hello Michaela, hello Stacy. Now here she is in her mid-90s. Her hands were lots of arthritis. She was wearing a diaper. It was a nice facility, but still the girls didn't like it. They were probably 5, 6 years old at the time. And I said to Susan, take the girls and go to the cafeteria. Someone want to talk to Nana Rose. So I said, what's this with Uncle Sid and Dad saying you want to die? And she goes, yeah, it's time. I go, it's not time. Look at you. I mean, you're sharp as a tack. Yeah. How do you even remember Stacy's name? You haven't seen her in 4 years. She's only 5 years old. She goes, Michaela, I remember your first marriage. I remember when you started to date your second wife. I remember when all four of my boys went to war. I remember when I got the telegram saying that your dad was shot down and presumed dead. And then the other telegram saying, I remember everything. Well, that's incredible. And she goes, no, Michaela, it's not. Look at me. I'm just going to say it. If you have to bleep it out, you will. I shit myself every night. She would call the remote control the clicker. It was the clicker. I can't even use the clicker. I have to call the girl to change the station. What am I doing here?
Right.
I see all these other people here. They don't know where they are. They don't know if they're eating Jello or a filet mignon. I do. And I tell you, Michaela, it's worse. And I'm like, well, we want to keep you around and we wanted this. And, a couple nights later, I'm back at Dad's house and he goes, so what do you think? What do you think about Nana Rose's situation? I said, I never thought I'd say this, but I'm kind of agreeing with her. She remembers everything, Dad, everything. And yet the body she's in is like a prison. Now, I can't say I'm not for euthanasia. The only reason I'm not is because we live in such a corrupt world. And there's a lot of crummy, crummy people out there. And that includes children, grandchildren, nieces, and nephews. And I can see it happening for the wrong time. But I know this is a cliche. It's not like I'm saying anything original here. We put our dogs down when they're suffering because we love them so much. But we
Right.
can't do that with grandma and grandpa.
Right.
There's something weird about that, but I also understand the moral and ethical, and although I'm not a religious person, religious, things that surround having a panel of doctors go, yeah, let's put them out of their misery. I understand the problem with it, but that, like, I'm sure like all human beings, you put a dog down when they're suffering. My God, you shoot a horse in the head when it's suffering. Actually, you shoot a horse in the head when it's not suffering. You just shoot a horse in the head when it breaks its leg. That should be against the law. That's another episode we'll have one day. Why you shouldn't shoot horses. But that's got to be paramount throughout caregivers and hospice workers going, my God, what can we do here that's legal, ethical, and moral, of course, but legal? They're
Right.
suffering. That's got to be a constant
People,
turmoil.
yes. And people will ask, I've been asked more in my career, like, kind of, they think there's like the magic shot, like that we're coming through the door with something that's going to put
Dr.
them out of their
Kevorkian.
misery. Yeah. So some people are scared to death. They're like, do you have the morphine? And then other people are like, where's the morphine? Like,
Yeah.
bring it. Um, but we do. And in hospice, having the benefit of, for someone like her, she would have had social workers, more interaction, more people to talk to, and that's the thing, like we want our people to live, but when they're living, we get to go home. They get, like my grandma Helen,
Yeah.
she's stuck. I mean, she can't drive, she can't make any choices for herself.
Yeah.
She's given what she wants, like you can't make a choice what to eat. And yes, it's a beautiful place, and but the day in and day out, and you
Yeah.
watch your friends, that you meet that get sick, and because everyone's elderly and everyone's there because they're probably not doing well.
Mm-hmm.
So it's very hard. And I think I mean, I don't want to use the word selfish, but sometimes like, we want to keep them in their little box so
Oh,
that
yes.
like, but their quality of life is terrible, because especially when your sound mind and your body fails. It's one thing when your mind fails,
Yeah,
and
you
your
don't know.
body's healthy, like,
Yeah.
and I had my grandpa, my mom's dad, he was
I
65,
remember him.
early onset dementia. This was a man, he was 6'5", worked
He was a
outside.
cool guy. He was one cool
Oh,
guy.
no health problems, but he had dementia. And this poor guy, and it was terrible. And he was so healthy physically, but he was so agitated because he couldn't express himself. And this was
Yeah.
a beautiful soul. I mean, he was a beautiful person who
He
ended up
was.
fighting people at the end of his life because he was so frustrated, and he ended up falling and breaking hips and getting infections. It was a terrible,
Terrible way to go.
and then you get people like Nana Rose and Grandma Helen, who they're just so old and their bodies are failing, but their minds are sharp, and they sit there and they've watched everyone they love pass away, and they feel like a burden. And it's very hard. And I found like a lot of hospice workers, we're educators, we're counselors, we're a safe place to have those conversations. And a lot of the patients that can have conversations, I'll kick family out, and we get down to it. We really talk
You
about
have
those
to.
things. And that was one of my favorite. I'm in management now, so I'm a little removed from the bedside, but that was one of my favorite things to do, is just kind of get to know,
Yeah.
let them know that that's okay, that they feel like that,
Yeah.
that it's normal. um I can't kill you. Like, it's
Sorry.
gonna happen when it happens. There is no magic drug, but if you want to eat your ice cream, if you're uncomfortable, anything that comes along, if you want to talk, if you want to sleep 20 hours a day, I don't care, and comfort comes in a lot of different ways.
Yeah.
So I think we're able to do that. And one of the pushes that we really, are pushing for is earlier referrals to hospice. Sorry, it's my dog.
That's okay.
When you know that you're truly sick and that you have all of these illnesses, and looking at patients who have been in the hospital multiple times, multiple infections, they're not eating and drinking as well, they're losing weight, and you know kind of looking at that and going, well, and then they keep going to the hospitals, and then they go to the hospital and they're laying in the bed and nobody gets them up. So then they go to rehab and then they fail out of rehab. Now we're looking at long-term care. And if you don't have money put aside, no one has $10,000 a month for long-term care.
Yeah.
And then it's just so having the conversations earlier. And one of the things I'm really pushing for and working in a large system, we're trying is really flagging those high risk patients, those patients that we see coming through the ER. Medicare doesn't reimburse the hospitals if they're readmitted within 24 hours. They don't reimburse if you're getting an infection when you're in the hospital, if you fall or have, a complication or stay up beyond your days, that you're supposed to be there. So you're starting to see, these hospitals really getting on board with having conversations, because having a hospice, so that will decrease the readmission rates. So it keeps them in the home, keeps them in the community, keeps them out of the hospital. Because, let's be real, if you're laying in the hospital bed waiting on a long-term care bed to open up, you're taking a bed away from someone. When you go sit in the ER for 6-7 hours, 2 days, that's why, because there's people just occupying beds that they have nowhere to go. The family can't take them home. They don't have money, and we see it.
It's heartbreaking.
It is. And then the patients just lose hope. I think we forget as people age that these are still human beings. They still have feelings. And just because they're quiet and they're old and they're in the bed doesn't mean that they don't hurt emotionally, physically. They know that they're a burden at this point. So it's very sad to me. So I love, if I can rescue you and send you back to your house and do it by using hospice and get you back home, like patients, their outcomes are much better. They live longer.
At home, yes.
They want to see their dog. They want to sit in their recliner. They want to, and so getting someone home and not having to run to the hospital. If something happens, you call your nurse to come to your house. It's really seeing it from both sides. And right now I work, so what I do now, we have an inpatient hospice unit within the hospital. So that's what I help manage. So we have 7 dedicated beds. It's a hospice unit. So it's an inpatient hospice. The criteria is you really have to be unmanageable. Like, I have to prove that I really couldn't put you somewhere else. And take care of you at home. So our patients live, national average 90 days in the home setting or home community setting, your nursing homes, your assisted livings. In my hospice unit, our average length of stay is 72 hours.
So they're really close to the end when you meet them.
Very. So we have an average daily census about 5.8. It's kind of weird, 5.8. But, so we see about 5 to 6 patients a day, just depending on the turnover. But, there's different levels of hospice care. And sometimes you don't meet criteria for that inpatient hospice. And we have to talk about, where are we going to go from here? But I don't know. It's definitely, I think people have such a negative, some people have had great experiences with hospice, but I think when hospice has been around for long, since the 60s. I mean, it's not anything new, but it's evolved. So back when when our grandparents, when it was kind of coming out, they were called in very last minute. So I think that the whole thought, well, hospice comes, they gave them 1 dose of morphine and then they died. And most people don't realize, no, these people are, like you said, just in your intro, people live longer. They have better access to care. And even at end of life, they do better. So, I think we're working through that. And then, like I said, not every hospice is created equal. Some hospices, like I said, they'll show up every 2 weeks. And these poor families are like, it's tough. And then you get a great hospice and there you're like, oh my gosh, but I think you got to ask questions, ask your friends, who they used, were they happy with the care? You can ask for a certain hospice. So if your doctor says hospice, they're going to go with the hospice lady that dropped off the cookies. They don't really, they're not, some doctors truly love a certain hospice, but there's a lot of, these hospices are for profit. So they're out there.
Which is okay. People got to get paid.
It's fine. And they're bringing bottles of wine and, they're enticing, which really they're not supposed to, but they do. But so just because your doctor says, well, I want you to use hospice A, If you know hospice B might be better, you can say to them, you do have a choice. So ask the questions. Don't be afraid to say, well, no, I don't want that hospice. Could you please call or send the referral to this hospice? And that is a regulation that you do have choice. And even in our hospital system, the hospital owns the hospice. We still, by regulation, have to offer choice.
Right.
They can't just say, well, you're in our hospital, you have to use our hospice. They can still say no. So that's something. So do your research, and you can look. CMS has a website. It's like a care compare website where you can go on the CMS website, and you can search for any provider. You can search for hospice, and there's stars. They're rated, and that comes from scores, CAPC scores when people fill out, surveys. So that's real data, and that's a true number. So if you really want to know if there's something in your area, hospice in your area,
You can find out.
go on that Care Connect site and you can see.
Well, I said, just let me quickly remind everybody, if you're just joining us, then you need to hit rewind and start from the beginning, because this has been a great episode. And we still got about 10 minutes left, but we're here with Miss Kim DeLeon, who has been with hospice for most of her adult life and has been a nurse her whole adult life, talking about what Angels Hospice is and what they do for not just for the patient, but for the client. And I said today would be more human interest, and we would talk about the normal things, but it seems like every episode we have, Anthony, no matter who the guest is and what we're talking about, it always gets back to that long-term care. And I'm going to tell everybody that's watching, because now the audience is just growing into huge numbers. If you're in your 40s, even 50s, 40s might be a little young, but if you're in your 50s, even early to mid 60s, and you haven't made these decisions, you don't have this documentation, if you think you can't afford long-term care insurance, you're probably wrong. That's another falsehood about long-term care insurance, that it's for the wealthy and that normal working people can't afford it. Normal working people might not be able to afford that incredible multi-million-dollar long-term care policy that the wealthy has, but there are just policies out there now available to people in their 40s, 50s, 60s, that cost as little a month as what your phone costs. And yet you can pay over it for 10, 15 years. And when that time comes and you need $6,000 a month or $8,000 a month, maybe it's not $20,000 a month, but at that time, $6,000 or $8,000 a month will be a godsend. And again, there's all that emotion. People don't like talking about it. Well, why should I pay premiums for something that I'm not going to use for 20 years? Because in 20 years, when you need it, it's too late. That's the reason why. There's no emotion to that. It's intellect. Stop. Right. Well, why should I buy it now? I don't know. Why did you buy life insurance when you were younger? Did you hope to die? Insurance is there to mitigate risk. So I hate to do it, but I am going to do it. If you're listening and you're in your 40s, your 50s, if you're in your 60s and still fairly healthy, get yourself over to www.62whoknew.com. Click on the LTC, long-term care insurance link, and at least get information. So you're not in the situation. What did you say? 76% of people are not. Is that what you said? 76%?
About 72% don't.
72% people are just not prepared for this, and not prepared mentally, emotionally, physically, and of course, the real life ender, financially. So in the last few minutes, let's talk about a few things. There are different levels of hospice. I think you hit the nail on the head 20 years ago when dad developed congestive heart failure, and on his about fifth heart attack in 1 year, when the nurse in the hospital, and he was coherent, he just kept coming back. Every time we went to the emergency room, they would say, okay, call your sister, call the grandkids. He's not leaving. And not only would he leave, he'd go home and go back into physical therapy until the last one, which I think was the sixth or seventh heart attack. And I remember one time, probably on his third or fourth heart attack, when a doctor said it might be time to call hospice. And our family, especially that generation, my dad went, what the F? Except he didn't say F. What the F did somebody say? Hospice? I ain't dying. I think because of the way it started, I think you hit the nail on the head. In the 1960s, hospice came in for those last few days. And it took everybody to convince my father, no, you're not dying. I mean, you kind of are. You have congestive heart failure. 3/4 of your heart isn't working. But you could be around for a long time. But now's the time to meet a hospice person. Now's the time to arrange what's going to happen. And he kind of begrudgingly gave in, but he immediately thought that word hospice meant death. So
Yes.
I know you told me there are 2 levels, excuse me, 4 levels of hospice care. Where you live on went on hospice, how long someone can stay on hospice, hospice criteria, and of course the goals of care, being prepared. Let's go over just a little of those, and that'll probably just take us right to the end of the hour. So where you live when you're on hospice, both
Hmm.
my mom and dad lived at home in a
Hmm.
hospital bed in the living room
Yep.
with in-home care. This family didn't believe in long-term care insurance, of course, so we paid for it out of pocket. That's life. That's how our family does things the hard way. But there was in-home care, skilled nursing, there was unskilled nursing to help with certain things, and there was hospice. So when you can't afford those things,
Hmm.
you do end up not just for the last 3 days of your life, like you're talking about, but you do end up in hospice care or hospice home.
So hospice will go anywhere that you call home. So whether it's in your home, family member's home, long-term care, skilled nursing facilities, personal care home. So hospice can go anywhere that you are. So that's what we call routine home care. So it's home care, but home is wherever, you live. So that's the first level of care. That's your basic per diem, your basic rate per day, the 100, depending on where you live. And then you have a respite level of stay. So if you are a caregiver in the home, you're entitled to a 5-night respite stay. It is a benefit of hospice. Some hospices don't love to say that they have it. They're required to provide that level of service.
Tell the audience, tell our viewers what respite is. And most people I've learned don't understand what that means.
So it's if there's a caregiver fatigue, so it's not used like, say you're taking care of your mom and you needed to have cataract surgery, you needed a break, you needed someone to help you out for 5 nights, or if you're just exhausted, hey, I've been up 24 hours a day with mom, it's hard. So if you need a break from being a caregiver or vacation, like over the summer, we've had a lot of families say, hey, I want to get to my granddaughter's graduation, but I've got mom here. So it's not something that if you say, well, I need it tomorrow, it's not something like that. So it's something that you kind of have to anticipate. Or if you're truly fatigued, that your hospice will work out for you and you'll go to a facility. For me, because we have an inpatient unit in our hospice, you would come into the hospital and then you go home after 5 nights. Other hospices, sometimes they contract with local facilities, nursing homes and things like that to get you a respite bed. So that's a benefit of your hospice. Medicare doesn't say how often you can use it. It's just hard, because most hospices logistically, just
Yeah.
depending, but it is a benefit of hospice. So if you have someone you love on hospice and you feel like you need a break and nobody's offered respite, ask about it. It is your right. And you can also change hospices. So if you're on a hospice right now and you're listening to this, you're like, gosh, my hospice is terrible. They don't have any of that stuff. You can request and transfer to a hospice whenever I mean, it's a benefit. So you
I'm
can
glad you said that. I'm glad you said that.
Yep. And a lot of people feel bad because they're like, well, I really like, the aide, but the nurse is terrible or, something like that. But you can transfer hospices. So back of your head. And then we have something called continuous care, which is if your loved one ends up having a symptom and they don't want to leave their home and they're just having a real hard time, they're having unmanaged pain, you've done all the things, you've given all the medicine, and you just can't get a hold of it, the hospice should be able to put a nurse in your home until that symptom is managed. That's like the highest level, paid level of care for hospice. Again, it's not as common because most of the time we can get things under control. But, if there's just times where you may need
Yeah.
that. And then we have inpatient care, which is what I do right now. Not a lot of hospices. Now, depending on where you live in Georgia, there's not a ton of those units. We're actually opening one in our hospital, and it's really neat. We work for a very large healthcare system, and they have been gracious. They've always, loved our hospice. We're a not for profit. So we help each other. We don't make them money, but we save them money. So they have actually, we have raised $18 million,
Oh my God.
all from donated funds. It's the first building that will be built in our system that is 100% donated funds. So,
It's
and it
incredible.
really, that says so much about our community in that in times of sadness, you take this terrible experience where someone they love have passed, and you have enough people in the community who want to give. It touches my heart. So we're going to open that. We're breaking ground this summer.
That's incredible.
Super exciting. But there is an inpatient level care of hospice, and it's really used for, we've done every single thing we can do in the home, and that patient's not managed, or in the case where our patients are coming from the hospital, within the hospital, sometimes taken off a ventilator, something where they just require too much oxygen, or they require, IV medicines, something that could
Right.
not be done in the home setting. We'll take care of those patients. So those are the 4 levels of care. But majority of patients will fall under that routine home care.
Right.
We try to keep hospice home-based if we can.
Yeah. Well, being at home, like I said, every study, as you said, every author we've ever brought on, whether you're getting better and you're not terminal, getting better or not getting better, you
Yeah.
live longer at home, you feel better at home.
And you can sign off of hospice. That's another. Now, it's not something you want to do back and forth. But I mean, there are patients who have just, maybe been on rounds of chemo, and they're just like, my gosh, they're just knocked down, and they just feel like there's no more they can do. And I've seen patients over the years that start to feel better because they kind of gave their bodies a break from all the medicine. And they'll be like, I just want to go check it out. Like, I want to see, has it grown? Did the chemo work? And we've had patients that have had to sign off.
Well,
So you can do that. We don't encourage the signing off, signing on, signing off, signing on.
yeah.
A lot, but we do have patients, or say, God forbid, if we have you on service for cancer and you fall and break your hip, we want you to get your hip fixed, so you could sign off of hospice and then come back on it. It requires a 24-hour period wait. So you're not glued into it. Some people are like,
It's
hey,
not a
this might
death
not be for me.
sentence. Yeah.
It's
Hospice
not.
is not a death sentence,
No,
which
it's
so many
really,
people think it is.
yeah. I mean, it's definitely, like I said, you'll have so much transparency because you're going to be honest with you with what's happening. But if it's not what you like or what you want, or you're like, well, wait, they put me on hospice. We've had some patients who maybe had altered mental status, families made decisions. They're like, well, we'll take them home. They get home, and for whatever reason, they start to feel better. And they're like, well, who the hell put me on hospice? And so we've had different situations, but it's not, if it's not for you, or you don't like your hospice, it's not
Yeah.
an ironclad. You do have decision making. That's why you just have to be informed. You have to know, ask the questions, read, look at the sites that the government has out there, ask your neighbors, ask your physicians, people that you love and trust. Most time you'll find someone who's had an experience with hospice in your community.
Yeah, I'm sure. I mean, the hospital that you work for, or work with, how big is it? How many rooms?
Well, we have 5 campuses. Our main campus, we can house about 680 some patients. We're level
Wow.
1 trauma. We serve Northeast Georgia, so we cover, we've got campuses in, 5 counties. We have rural hospitals, and we have our main hospital.
So
Um,
thousands of people you serve.
mhm. Just our hospice alone, we have about 200, about, I was just say about 200 patients in the community. And then we also have a palliative care, which is kind of like, best way to explain it is just kind of like it's a precursor to hospice. You're not
Yeah.
really on hospice yet, but you might have pain or symptom management needs, but you're still wanting to pursue other kinds of aggressive treatments.
Hospice 2%.
Yeah. So
2%
we have
light.
about 200 patients in that program. So our hospice alone serves about 400 patients.
So I'm assuming that once I send you the link, or once the producer, Anthony, sends you the link on the show, this episode will be showing on every television on all 5 campuses, so they can see what you did and how well you represented. So we'll send that to you and make sure it's put out. Patients should be watching this on a constant loop. No matter what channel they go to in hospice, it should be you going, this
Oh
is
my gosh.
Yeah, that's what it should be. Thank you for being here. Thank you for being our guest. Thank you for being the angel that you are to all the strangers that you do and help every day. Thank you for being the angel of the family. Thank you for taking care of Aunt Helen. What else can we thank you for? Just thank you for being you, because you are an angel.
Oh, well, thank you.
Love you. Thank you for being here.
Love you. Thank
Bye-bye.
you. Bye.